It's my privilege to introduce Richard Morris for tonight's lecture, who trained in psychiatry at 7 Google in Leeds, Johns Hopkins in Baltimore, Oxford and Manchester.
Yes, that's it.
Yeah. Right, is it? That's my God for that. He was previously a senior lecturer in psychiatry in Manchester, a professor in Liverpool, before moving to Nottingham's Sub-Department of Psychiatry as Professor of Psychiatry and Community Mental Health. His research interests include the management of bipolar affective disorder and depression, but I was also interested to find that you can purchase him on Amazon, or at least his book, Psychiatry and Medical Practice. He's also worked on computer-aided analysis of facial expression in depression, so next time your computer says, "And how are you?" you'll know it's his fault. So, as one of the very few psychiatrists that have lectured to this society, I'm delighted to introduce Professor Richard Morris, who's going to talk about the modern medical management of mood disorder. Thanks, Richard.
Right, thank you very much. Thank you very much. Actually, this talk came about because of a comment I made at the last Chai summer ball, where I said, why does mental health not appear in ever? So they said to me, Bill said to me, well, in that case, why don't you do a lecture? So here I am doing this. So I'm very grateful for you to come out on this rainy, cold February in half-term week to come and hear this. It's a real privilege for me to speak in front of you. So I'm going to not speak about all of mental health. I'm going to speak about mood disorder and try to outline how a direction in which I hope it will go. Some of it is already going that direction, but it'd be wrong to say that everything I'm going to talk about is now currently in practice, although almost all of it is in prototype form or being tested. So I thought I'd better tell you some of my conflicts of interest, because I have a fair number of them. I'm going to talk a little bit about Clark's later on, and I'll try and explain what they are, but obviously I'm very for them. I chair a NICE guideline group, and in particular this work is informed by the MindTech. We have an NIHR, Department of Health, funded health technology cooperative in mental health. And this is for the whole country. And this is a wonderful opportunity because I get to mix with engineers, computer scientists, and all sorts of things. And some of what you will see is related to that. I'm not very involved in the pharmaceutical industry, and I don't do any private work. So I thought I'd better just... Normally, I have to say these things. Now, I'm going to try and give you an upbeat view of mental health. And maybe I do have an upbeat view because I actually work in a futuristic environment. The building that you see there is the Institute of Mental Health, and it's next to some other important buildings in this line. So it's next to computer science, and down here is the centre. There's some really sinister buildings. This is one. It's one called Horizon. It's the Colin Campbell Horizon's in there, and that spends its time trying to find out sneaky ways of how to get into make your data not private anymore, and then to try to stop them. So there's that. It's also next to the Satellite Centre, which is really sinister. It can plot what you're doing, where you're going. I'll show you what it can do. And that's next door. Back here, mentioning the pharmaceutical industry, this is GlaxoSmithKline Beecham's new factory. So it's a futuristic approach. I tried to find what I used to work in. I sent a picture to my old professor that I used to work on, and I couldn't find it. It just shows a rather stark contrast to this environment. So here's the challenge. I can't do this without explaining a little bit about the challenge. Potentially, it's a very big challenge. So mental health problems affect 1 in 4 people. And apparently, according to Lord Layard, who's a professor of health economics in London. It costs around £105 billion per year to the UK. It's the largest area of UK health spending at 11%. To give you some idea, that's twice what we spend on cancer. It's almost twice what we spend on heart disease and stroke combined. So it's quite a lot that we spend on it. And if you included learning difficulties and substance use and what we use in social services, it would be a lot more than 11%. So unfortunately, it's high unmet need with little technological innovation. We're still in the dark days of subjective clinical assessment. We don't have objective measures. We don't have the equivalent of the ECG or an X-ray to guide us. And that means that practice is very variable. What we're mostly dealing with are sort of chronic, recurrent, long-term conditions, and they require self-management. Medication is only partially effective on the whole. Psychological treatment is costly, and actually you don't get very many people can access it at any one time. So the whole area is manageable with difficulty, and there's a need for technological innovation. There's a need for doing things better, perhaps more than maybe some other areas. So I'm going to assume you know what depression is, but just briefly what bipolar disorder is. So, and in the context of that, I can explain what depression's like. So mania, bipolar disorder refers to two poles, mania and depression. So you can have mania, which is an elevated and expansive and irritable mood, with or without psychotic symptoms, auditory hallucinations, delusions, all sorts of things. And it usually impairs you, stops you from doing things. You can have hypomania. Hypomania is the same sort of thing, but you don't get psychotic symptoms. And people often believe they're functioning better. And what happens with mania, and particularly hypomania, is it's rarely the person themselves that comes to see me because of their problem. It's usually their relatives that bring them, and other people who are around them. Depression, on the other hand, is something that people feel strongly about and suffer with. And that can become in mild, moderate, and severe, and you can have psychotic symptoms with this. Then there's rapid cycling states, at least 4 per year. I'm going to show you someone who has a lot more than that. And mixed states, where you can have all of these things together. So it's a complicated disorder because you can have almost anything with anything else. Bipolar disorder is interesting because it's linked with creativity. So most of the bipolar disorder is a highly genetic disease, and people have speculated, well, if it's so damaging, why is it still in the gene pool? So on the top is a list of people that were supposed to have bipolar disorder. And on the bottom is a modern-day equivalent of Ozzy Osbourne, Jean-Claude Van Damme, who tell us they have had bipolar disorder. And you can see that there's a lot of high-achieving people who particularly work in areas of creativity. So just to point a few people out, because it illustrates something about the disorder. So down here is Paul Gauguin. Now, Paul Gauguin was an impressionist who lived in France. For some reason, and this is typical of someone with mania, he decided to go off to the South Pacific, and he lived the rest of his life in Tahiti and around there. Unfortunately, he committed suicide, which is the other bad thing that happens to people with bipolar disorder. Jackson Pollock, we can be more sure about having bipolar disorder because he lived through the 50s and 60s, so there actually are some proper records with him. He's a complicated man, a painter who produces painting like this. He not only had bipolar disorder, he had substance abuse, he had anxiety, and in fact, those are the common things that go with bipolar disorder. And he died when he was 44, having produced an amazing amount of work. He actually died of a road traffic accident, which is the other main way that people come to a premature death with this condition. So these conditions are more conditions that affect you in terms of disability. and depression is actually the second leading cause in the world for that problem. But bipolar disorder is 18th. And one of the things that we're grappling with at the moment is that still to this day, people don't need to know about this condition when they're in training in their F1 and F2 state. They don't normally get taught about it during their GP training. Yet this is the 18th leading cause of disability in the world. So why is this not taught? Depression is, and there's quite a lot of teaching about depression. But that's just to put it into context. Mortality. So mortality in younger people is by suicide. Suicide's not an uncommon cause of mortality in younger people, so it's the third highest cause. Second in countries like this country, only after road traffic accidents. But later on, even when you control for all other factors, you're twice as likely to die from heart attacks, you're likely to get renal disease. It's not just because some of them are on lithium, which is a drug which affects the kidneys, and respiratory disease. So normally around about, as I understand it, around a third of people would die of heart disease and stroke. But in this group of people with bipolar disorder and people with recurrent depression, it's half. So half the deaths are due to this. There may or may not be, it's disputed, whether as an increased risk of cancer. But it is particularly these sorts of things that people die of. And depression, if you get it and you happen to be vulnerable in other ways, is not a good thing to have. So these are studies from Holland, Netherlands, as the reference. And you can see here that that's the normal death rate at the top. If you have diabetes or depression, that's your death rate. If you're unfortunate to have a heart attack, depression, and diabetes all at the same time, that's your death rate. It's not a good thing. If you look at cardiac mortality, again, there's quite a big separation from the other conditions. So it can be, that's the context of it. So it's common, it disables you, it's recurrent, and the current landscape of practice is that we basically rely on structured self-assessment, secondary talking to people, and there's long waiting times, fixed-term treatment, limited follow-up, and limited chance to monitoring, because there's just too many people for us to do this. But the good news, at least from a technology perspective, is that these conditions disproportionately affect younger people. So the average age of onset for bipolar disorder is somewhere between 15 and 19. And depression is something that affects all age groups. So there's a potential here to do things with technology, because who knows about technology? Not people like me, I'm afraid, even me speaking in front of you, but people that are much younger. Now 90%, greater than 90% of people have a mobile phone in the UK, and the other interesting thing is 60% in Africa do. So there's a real potential here to do something with this. And one of the things that we do at the NIH Health Technology Centre is we help the Department of Health judge and Department of Trade and Industry to judge which British companies to support in this area. There are more applications for mental health and technology than there is for anything else. And I think it's because people see that younger people will use technology, therefore there is more opportunity. So there's a hope. These are what GPs and IAPT services now complete and use questionnaires on a regular basis to assess depression. So this is by far the most common used depression. Free for anyone to use, because it was given as a gift from the Rockefeller Institute. And you can get scores, and this is the sort of thing that mean, but mostly we do this by paper. You can also ask questions to screen for depression. Up until recently, GPs were incentivized to do this. I understand that incentive is now being removed. But now you can do this by app. And this app is now free to anyone to use. And I encourage all my patients to use it if they can. They make money out of the app by adverts like that one. But it's really quite useful because you can repeatedly assess yourself. You get a series of screenshots. So PHQ-9 tells you there are 9 screenshots or 9 questions. So there's the first one, and there's how is it scored. matters perhaps less what it actually says for this talk. And you can even get guidance about treatment, and this can be sent to your doctor if you want. And furthermore, this isn't you can get graphs that come out of this. This is one from the PHQ. This is from another app. But what I find useful is that I would spend maybe 10 minutes trying to establish how depressed has someone been in the last 6 weeks or a couple of months. Instead, they just show me their phone. And that saves me a lot of time because I don't have to ask those questions. Instead of them struggling to remember what they were like 6 weeks ago, if I asked you, what were you doing 6 weeks ago, you'd have to think about it. And it takes a little while. So they can just show me. It's probably more reliable than my questioning it would be anyway. So that allows me now to say, well, that week was not so as good as that week, so what was going on? Or that week was remarkably better, what's going on? So that saves time, and that's the sort of thing we can start to do. Now, as I said earlier, people can be very bright. It's not come out very well, I'm afraid. So I've got all sorts of clever people who monitor their mood with bipolar disorder. This is someone who has extremely rapid cycling bipolar disorder. And he produces this for me every time, as do other people. And you may not believe it, but that's actually better after treatment. It's slightly slowing down. And he helps me by giving me also this, change data. And now there's starting to be apps. I've seen one literally this week when someone came in and showed me an app which can do this, but that was actually an Excel program. But people are now starting to do this. So this is already here. This is not a vision for the future. But the problem is that, so what can happen is that as people become really depressed, they lose their motivation. As they become really elated, they become disorganized and frankly don't care whether, what people think of their mood. So we do need more objective and automated measurements of mood. And also, there are some people, many people don't have the skills to be able to show you the kind of graphs that I've just shown you. It's not everyone can do that. So we've been wondering what we could do with this. So I'm first of all going to give you just a quick case and show you what you could do with this, because there's more to it than just measurement with depression. You have a 30-year-old woman, a third episode of depression. She spends most of her days when she's depressed in bed, neglecting children, neglecting work, and they suffer as a result. She feels hopeless, she lacks motivation. The symptoms of depression are only overcome because of her sheer willpower. And she gets by just doing the minimum for those children. Now what we can do, weekly objective measurement of facial expression and voice. This indicates a small improvement in the depression. The doctor can use this information to motivate the patient to get up. Look, it's really worth trying to do this. There seems to be an improvement in your depression. Try and do one task each day, getting up around about, say, 10 o'clock, or so you're up and about, rather than spending the whole day in bed. And after a while, that kind of behaviour can be as effective as using antidepressant drugs. So the problem is with things like the PHQ-9, if she completes it all anyway, patients with depression always tend to be pessimistic. They tend not to believe their own opinion. Even if they come to see their doctor, quite often they don't believe what the doctor says because they think we're going to jolly them up and pretend that everything's better than it really is because we want to act in their best interests. So what can you do? You can start to measure these things. So what we're trying to do at the moment in Nottingham, and I have to explain that this is not just in Nottingham, this is a European effort, is we're trying to do audio-visual monitoring at home and in the clinic. So these are the sorts of things that you need. We need a camera, we need a microphone. I've got a phone here that we've got a good enough camera and a good enough microphone to do this. That's not the difficult part. The difficult bit is integrating all of this. So we could use facial expression and non-verbal speech analysis to measure depression-related cues automatically. We can monitor at home. We can do it in situated scenarios. And we can feed this information back, and possibly also to the clinician. So this is what this sort of thing looks like. So it's fortunately, our facial expressions seem to have a similar facial pattern, which you can actually measure in a standardized way. So here we are. Here is a woman here. You can look at the eyes, look at the mouth. These are key areas. And then through a process of this, you can detect the emotion. So this is a slide from my colleague Michel Valstar, who I work with in the computer science. And this is the sort of thing that we're getting at the moment. So we've got over here a graph of what's called valence. And valence just means the mood itself. So we've got, this is valence, pleasure and displeasure. And we've also got something called arousal, low and high. This may be very important because high arousal with depression may be related to suicidality, which is obviously the main risk with depression. So at the moment we're plotting this. The Nottingham part of this axis, which it includes Imperial and Brunel and places in Scotland, as well as across Europe, is to develop the facial expression. We're also not intending to rely just on facial expression, but also the measurement of speech and tone. If you do any kind of psychiatry training, you know that you're supposed to observe people and how they speak and how fast they speak, whether it's on a monotone, if it's slow, if there's a delay. Now, all those things can be measured far more accurately by a computer, I would say, than they would be by humans. So, it's not just depression. I put this slide in to show you something else that can be measured. It's not a mood disorder. It's attention deficit hyperactivity disorder, which is a disorder which is becoming a real problem with children. Something like 5% of children suffer from this. But if I was to tell you that children, from the age of 5 onwards are being diagnosed with this, and that the treatment for it was stimulant drugs like methylphenidate or possibly even dexamphetamine, then you can see that there's a bit of a problem if this is just a subjective diagnosis. And so this is a piece of technology which we're trialling at the moment to see whether it makes any real difference to decision making. And essentially it measures, this is attention and hyperactivity, and we've got norms down there which I know you can't quite see, but computerized assessment of attention activity supports clinical decision. And we're starting to move towards more objective measurement of not just mood, but other things. It's not just the assessment of mood we can look at. We can also automate psychological treatments. The truth is, we haven't had any real developments or real improvements in drugs for some time. There may be new drugs, but they're just cleaned up versions of the old thing. If you're familiar with imipramine and amitriptyline, and if you say that things like fluoxetine, an SSRI antidepressant, was a major advance, then there hasn't been any real major advances since then. And furthermore, there aren't too many signs of any on the horizon either. In bipolar disorder, possibly there's been some more developments, but again, it's not looking particularly great what's going forward. What there has been, though, is some exciting new developments in terms of psychological treatments and a better understanding of how those things can work. The problem is we'll never develop a workforce large enough that we can afford to meet this demand. So I'm trying to estimate, we could employ tomorrow, if we had enough money, the entire sixth form of every school in the country, and we still wouldn't meet the need of, for this. We certainly couldn't afford that. So it's impossible. We have to find another way of delivering these treatments if we're going to move forward in this direction. So we have invested an awful lot of money. So this is, those of you who work in primary care will know about IAP services, called Improving Access to Psychological Treatment. Lord Layard, who came up with the £106 billion, or whatever, roughly, that mental health problems cause every year, worked out also that it costs the country 1% of its gross national product just in depression. And therefore, if it would more than pay for itself if you could return a sizable proportion of those people back to work, and given that these people were mostly of working age. So there has been a big investment in this. And so within about a 4-year period, the first 1 million people have been through this process. That's an enormous investment, an enormous effort to deal with depression. But it's still not enough. Less than 1% of patients with serious mental illness get psychological treatment. It's a drop in the ocean. NICE recommends these treatments all the time, but the problem is not much of a solution to a problem that's so common. So what can we do about this? Well, the first thing is that you now can get computerized psychological treatment. Any of you tomorrow can get onto Mood Gym. This is just one screenshot from it. And it's reasonably well done. There's characters that sometimes look a bit like Sims characters, if you know what that game is like. There are also other alternatives if you don't like Mood Gym. They all tend to have quite good names. So there's Living Life to the Full is another one of these. That's from Scotland. Mood Gym is from Australia. There's one called Beating the Blues. You know, there's a number of them. If you want anxiety, there's something called Fear Fighter. These are all packages that, you know, you can get. Living Life to the Full, Mood Gym are completely free to anyone. You just have to put that into Bing or Google and you'll soon get this up. That's fine, but it does leave the person entirely on their own to do it. So the person has to motivate themselves to do this. And obviously, if depression affects your motivation and it affects your concentration, then maybe, you know, that isn't enough. So the thing that we've just got a small amount of money to start developing is what we've optimistically called the SAINT, which stands for Sensitive Artificial Intelligent Narrative Therapist. And so this is personalized CBT. The way we see it is there's not only a problem delivering the therapy in the first place, but I have to only let you have the therapy once, which is a bit silly when you've got a condition that's recurrent. So what we thought was the therapist could set this to deliver responses, but it's responsive to you. So you say something, it says something back. So there's the person, and there's perhaps could have been a smiling face rather than a sad face, but it'll look like that. It's obviously a simulated picture, and it responds to how you look. So it uses some of the same technology to look at your facial expression that we've already talked about and how you speak, but it also responds to what you say as well. So this is just shows you the kind. You know, it's my computer science colleagues showing you how they actually do it, at least schematically for lots of boxes. Now there's one of the most exciting developments, and this isn't really in depression, well there is a variation of this on depression, is a new treatment for schizophrenia which seems to be effective. And what this happens is that you create an avatar. So this is a woman's avatar to create an image of something that she can only hear. So she hears voices. But one of the things that's so difficult for people with schizophrenia is it's too abstract, it's too tenuous. You know, it's a voice that's following you around, making comments about you. And it never stops. So it at least gets on your nerves, if nothing else. And the content of it can be distressing. By visualizing it, you can start to have a conversation. I mean, this will respond to how you respond to this. And it's an intelligent response as well, so it will respond to this. So what you get is people with schizophrenia now saying to their voice things they've always wanted to say. And you can shape that. So this is not just done on their own. You have a therapist there as well who will shape what that person says and veer people from saying certain things because it's not a good idea. If you repeat this over and over again, you can actually make the voices more muffled, more saying more pleasant things than perhaps they would do, you become less fearful of it. A lot of mental disorder is based on fear of what might happen. So this is an avatar. But they haven't stopped there. So the same company also creates something to give instructions and respond to people with severe depression. Theoretically, you could use this for all sorts of things, any disabling condition. You can also use things like we've just seen and funded a proposal with the Department of the Trade and Industry for someone to help people come out of prison. So before they come out of prison, they create an avatar and they discuss certain things that they wish to sort out beforehand, and it responds to them, so they can practice before they come out of prison how they wish to interact in the outside world. So there's all sorts of possibilities. I wasn't brave enough to try and create an avatar in this room, but it's one of the things I would have liked to have done. But anyway, it's an interesting direction. This is another thing, a much more low-tech thing, but a lot of people, particularly young people, lack a huge amount of confidence, particularly if they have mental health problems. If they have mental health problems when they're young, some of them come from very bad backgrounds. They've been sexually abused, physically abused, and maybe been in children's homes, all sorts of things like that. And they just find it difficult to speak to people, including people like me. Hard to imagine, but they find it hard to speak to me. And what this can do is they can arrange to say, they can set their agenda, they can say what they want to say to you before you arrive at the treatment. And in Nottingham, this is a reality. It is also in Derby. People can do this. As a therapist, you're supposed to take this seriously and respond to them. It does other things. So it can analyze, it can measure your mood, it can do some of the mood things we've already talked about. You can set your own plan, it can remind you to do things, it prompts you to go to appointments. And certainly that sort of thing has improved my DNA rate in my outpatients considerably. So this is called Buddy App. At the bottom there is we've been considering whether we could dare give this to people who self-harm. It's a project that we're currently in setting up. It's funded and setting up. We've been wondering, can we do this? Our fear being that what they might send us is, I'm going to commit suicide, and how do we respond to that? But here is an account of someone. So Jenny, 15, repeat self-harm and depression, said that what she liked about this system was that it was easy to use, and she could see from her diary entries that there were periods when she was felt okay, rather than just thinking about that her mood was bad all the time, and this made her more hopeful. The way these things go is that you build on a small amount of success, and you build up gradually until people improve. So that's another type of thing. It also, in mental health, there's a whole raft of these sorts of things to help people link up. So people are isolated and on their own. So social media and this type of thing have a huge amount to offer to link people together. So here's just a sort of summary. So this is a summary of the things that are currently in our mind tech thing. So we have the conditions we're looking at the moment is depression, ADHD, bipolar disorder, Tourette's syndrome, Asperger's syndrome, and post-traumatic stress disorder. So there's those kind of problems that we're trying to deal with: subjective assessments, time-consuming, low diagnostic accuracy. And there's a solution. I've shown you that. Poor treatment adherence, missed appointments, lack of objective monitoring, and trying to improve psychological treatments. So I'm going to talk about my PET project. I've made a lot out of this over my years. This is my, it's probably why I got my professorial appointment. And I'm amazed at its longevity. About two grants ago, I said, surely this is now in practice enough. We'll never get another grant. But the one thing you learn in research is get a good idea, hope it's not put into practice, and then you can recirculate it over and over again, because everybody wants a track record of previous success. So we have a track record. So I've now studied this as firstly as an intervention given by a psychology assistant who costs about $10,000, costs less than a secretary to employ. So it's relatively cheap. That worked very well. Got into the BMJ with that, which is quite good. Then I've developed this into a group treatment. I've developed this into an internet treatment. I've taught it to community mental health terms in a training package. So now I'm trying to develop it as something which you can use technology for. What is it first? I'm also lucky because this is in the NICE guidelines and in almost every other treatment guideline that you can see around the world. And it's also very popular with the Bipolar UK, so it's there. They advocate this form of self-management. So what is it? At least 1 month after remission from acute episode, people who are still in an episode of mania or depression are not interested in preventing the next episode. All they're interested in is how to get out of the current one. But when they do get well, you can have a conversation about stopping the next one. The truth is, if you have bipolar disorder, you're likely to have 12 of these episodes in your lifetime. So it might be worth thinking about how to prevent this. So recognise the early signs of mania and depression. They're individual to each patient and also different from mania and depression. You get about 2 to 4 weeks warning compared to not doing this for mania. A little bit more variable for depression. It's popular. You can deliver it in various ways. We're looking for 3 early symptoms of warning to do something about things. If you're having mania, maybe reduce your activity rather than increase it. You can use a small amount of extra medication, a fraction of what you would need if it was a full episode. And then 3 later symptoms. At that point, you can do this on contact services. So what we do at the moment in Nottingham, we've only just started doing this in Nottingham. It was a research study, now it's in practice. And the reason it's in practice is because the patients want to do it. I've been showing people the results of trials, NICE guidelines. None of it made any difference. What made a difference was some patients going up to a trust board meeting and telling the trust board that they wanted this treatment. So it's difficult for a trust board to ignore that kind of pressure. That's what matters. So the group, teach them how to do this. And then I've had people contact me from the Siberian Express, from Thailand, from all sorts of area, saying to me, I think I'm developing signs of mania. They say they've already got medication with them to deal with this. What do you think? And then I text back and say, yes, I think you have a point, or you email them back usually rather than text them. They may show me a plot of their symptoms. So I then agree with them, and then they put it into action. And certainly both of the people in Siberian Express and in Thailand and another one in Singapore, they're all completed their holidays. They didn't come back. They didn't find themselves off in some hospital in the middle of Russia or anything. So it does allow people a lot of freedom. But there are still problems with this. The truth is that some people, you have to be vigilant all the time, and some people don't respond in time. What would happen if you could do this automatically? So here is a checklist of symptoms. So one of the things I've done in my research is develop these checklists and validated them. We can use these checklists to see the sorts of things that we need to pick up. So what we want is this. What are the early signs of being relapse? We don't want things that are too late, and we don't want things that only occur for relapse. So this is the mania checklist. Ideas flowing too fast, senses seem sharper, more talkative, racing thoughts. Later on, colours become very bright, can't concentrate, feel emotionally high. These things this particular person doesn't get, but other people might, feeling creative, feeling irritable. Stronger interest in sex, fortunately only in full relapse. And then here we are, here's the technology we would require, and this is the sort of things that you could do. And these are the sorts of numbers of people that would benefit from it. So these sorts of things, actigraph, bed sensors, home sensors, satellite tracking. Yes, it's all quite Big Brotherish, and I wondered whether anybody would do this. But greater than 75 participants in our data set would respond to this. Speech, text, use of IT, you can use things. We mood and self-descriptor ratings that are texted. Games are good ways of picking up whether people feel subjectively colours are brighter, sounds are louder. Monitor bank accounts. Would you really think anyone would do that? Apparently they do. And there's some other things which people even allow us in their bathroom, in their kitchen. Now, I wondered, when first someone came to me with this from electrical engineering, from the satellite unit, and our first response is, well, nobody will ever do this. It's, and maybe it might make some people really paranoid. But actually they will. If they're desperate enough, they will do this. So this is the sort of technology you need. Now, I see this. We have done this in 5 people. So 5 people have agreed to do this and done this. So this is when I show you data, it's from those people. And this is with John Crow, who's a professor of electrical engineering. So we're using various forms of personalised ambient monitoring. Is just a way that means it's portable. And so we usually do as much as we can through a mobile phone, but we need other things because we need to capture a range of different symptoms. We can use environmental things. These are things that really have to be in the home, but they can also be in the car. I'm not sure about things like car insurance if you start modifying cars with this kind of thing. That's one of the things that we have to work out, but you can certainly do things in the home. You can actually even do things on the environment. So these are just the sensors, and these are just the way that these things look. That's what they literally look like. And this is the kind of thing that you see. So you can wear it on your pocket if you like. It looks a bit like a phone. These are the sorts of things that you use. I can go through this a bit more quickly. So we use light. So this is what someone's data from different light intensity. We can also see how where people are. This is the sinister stuff from the satellite center. So this is one person's movement. But you can highlight areas that are meaningful to those people. You can see where they're going. And if they go to certain places too often, it's an indication possibly that things are not well. You have to work it out for each person. These are sorts of games that we use. So it's not just use. I mean, obviously the biggest use perhaps with children, but adults also quite like using them. We use them for diagnosis and treatment, working with children, adults, with poor attention and motivation. The games can be also used to treat. We use it in this situation to look at intensity of colours and other senses. And the beauty is that you can design these things so that people don't know that they're doing it. It's still entertaining enough for them to keep doing it. So there's another example, one down there. Now, all of this would be no use unless you could integrate it. So this is actually stuff that came from wind farms. And we're using technology from wind farms to integrate all this together into a circuit, a flexible program. And you set rules, so you set limits on all these sensors. If it goes past this point, it might be an indicator of something is wrong. But you never use only one of these sensors to indicate anything. It's the combination that means something. It's flexible in sort of programming. It's also, unlike the other system, you can also control who sees this data. So you can, if you want someone to see it, such as your carer or partner, you can. There are also ways of stopping this. If someone's, if you have a bathroom sensor, you do not want everybody all the time, people detecting things in the bathroom. Or bedroom, for instance, but you can switch it off. This is the kind of circuit that you end up with, and it allows the clinician to do some things that you can't do at the moment. So yes, you can detect things more quickly. Clinician can also send out information and then monitor what the response is in terms of the same sensors. So it can see if it's working. If it's not working, you can go to plan B, or plan C, plan D. So this is the kind of thing. One envisages, well, the way we envisage it is a bit like getting Sky fitted. Someone will come along, fit these sensors, show you how to work it, and off you go. At the moment, this is a prototype. We are waiting to see if we can get funding out of some venture capitalists to really do this on a bigger scale. It will need to be trialled, because something as intrusive as that will have to go through a technology appraisal with NICE before it's allowed to be used. These groups and this sort of approach are just trying to show you that they can have long-term effects. So this is a study from actually from Spain, showing you that even 5 years later there's a difference between these two groups. Now the other thing that we have to do, I mean, we have a condition where we have, you know, a very common problem. We also have some very severe people, and at the moment they don't get a good service either. So we're not doing very well at all sorts of levels. If we do want to use our specialist input, then we really need to concentrate that resource. So we have self-management with general support perhaps for some cases, and maybe periods of time of specialist support for a limited time. But we also need to think what we're going to do with the chronic severe depression. So NICE says that these people should be getting both psychiatric and drug treatment. And this is an audit of what's going on in Nottingham and Cambridge, and it's not very good. We did this as a Clark study where we were allowed to perhaps do things we wouldn't otherwise be allowed to do. So diagnosis with assessment's not too bad, but the rest of it is not brilliant. So even people with a significant suicide risk are not followed up as frequently and as quickly as they should be according to NICE criteria. And they're not getting the kind of follow-up they should be getting either, not even with the support of the GP. The treatment length is not good enough, the interactions are not considered properly, discontinuation symptoms are a problem, people are not recording or explaining these things, and general side effects are a problem. Even worse when you get to psychological treatment. So about a third of people manage to get some psychological treatment. That would be bad enough, but when you know that all they're getting is 7 sessions and NICE says they should be getting 16 to 20, then you know that this is not good enough. So one of our patients recorded a video. Again, this is one of the things perhaps I should have brought along. And he tells, if he was to see it, he says that 7 sessions is just long enough to remind you of all the problems that you're trying to forget without teaching you any way of coping with it. So actually, these people not only say this is not acceptable, but it actually makes them worse. So this is what we are doing. You know, I'm not proud of it. It's what we're doing. So surely we can do something better. So one of my favourite slides, I often use it. The problem is, how do you get innovation from things like research, any of those things? How do you get them into practice? The truth is, there's all sorts of problems all along the way, and these are some of them. And basically, it's really more by luck than judgment if you get things through, and perhaps a lot of determination as well. But it could get held up at any kind of level. So what you tend to get is more of the same. Another one of my favourite slides, this is what happens with implementation. Implementation of things. You go around in circles, up and down, all over the place. So all up here, all around here, all around here, and around here, and eventually you don't get anywhere, and you need a miracle if it's actually going to happen. So the other things that we're trying to work on is new approaches to service design, and this is where the Clark comes in. So the Clark is a applied healthcare research centre, and to my mind, Peter Jones from Cambridge said, what you are doing, Richard, is social systems engineering. And I like that phrase, so I thought, social systems engineering. So implementation is not left to chance. We design it using networks, but hopefully the networks are effective. Why do we need networks, and what is a Clark? So the Clark, we did have one had one in Nottingham and one in Leicester. We had to combine. We've got a bigger source of money, but we have to share it. So we now have a Clark in East Midlands. It's been going since the 1st of January, so not been going very long. It's built on a lot of existing work. So Clark projects are not just pieces of applied research, but they're all supposed to lead to changes in practice. They're performed when there's still one piece of evidence that's needed. So quite often, you know, the evidence has been collected in hospitals, but the practice is in community because the government has decided so. But the trouble is, it doesn't immediately mean that everything you can do in the hospital can be done in the community. We all know that. So what the Clerk is a model of practice. And because it's evaluated, and if you do it in a particular way, you can learn all your mistakes while you're setting up this model of practice in this Clerk way. And also, if you want to get this across the whole of the region, you get buy-in from across the region. So I go around seeing chief executives and medical directors, trying to get them to release staff, because we use the staff that would deliver the intervention in real life to do this. And we're looking to train a workforce. So in one go, we're doing a research project, we're creating a model of practice which is hopefully sustainable, and we're training a workforce to deliver it. The people that we ask to do this, you know, it's definitely see one, do one, teach one kind of exercise. So we're expecting people, not for psychological treatments, which I tend to do, probably you need to do 10 or 12 before you teach anybody. But nevertheless, the idea is you develop a workforce like this. So we look systematically for barriers, and we know the sorts of things they are. We've got this acronym which is called POETS, but it stands for think of barriers at policy level, organisational level, educational level, economic level, treating team level, service level. We use the team itself to solve the problems. And no longer is my problem to solve everything. In fact, it's better if I don't. Because people solve their own problems. When they solve problems and they build something, they become committed to it. If I just do it and then pass it to other people, then it's my thing. But it's their thing. You see, I hope that makes sense, because that's the key to this. Often blocks are attitudes. Sometimes they're technical or practical. But generally, you can get things done more effectively. And we use things, technically these people are called knowledge brokers, and they're professionals who work across research and clinical practice. They have their own professional networks. It's important. We use quite senior people for this role, often not confined to just one geographical area. Sometimes it's confined, you know, in one role or one profession. And then we created these things called managed innovation networks. So I've called them IMINs, not MINs. IMINs are to indicate that these are not just within one organisation, but across organisations. So ideally, it's across community, primary care, secondary care, not just in Nottingham, but in Leicester, Nottingham. This example I'm going to give you was in Cambridge as well. So you lead by a knowledge broker of some seniority. They're given the time. We train them to do it. They're supposed to be supported in their role. The MINs are formed of service users, research teams, and clinicians. We invite managers, invite commissioners, but they're not there all the time. We meet maybe 3 times a year, no more than that. But it's a purposeful meeting with tasks to do in between. We identify the barriers to research and practice. A key thing is that knowledge brokers are people who want to do this in practice. Now, people like me are interested in research. Unless it's really my clinical area, I'm just going to go once the research is done. You know, it's a sad, you know, my job is to move to something else, not hang around. These people are people who would be committed to doing this in normal life, if you like, and they campaign for this to be put into practice. So we also try to identify practice that can't change. These are usually services. Services have to have many different facets to them. You're not just delivering one intervention, you're delivering a whole load of things. But so services are based on models of practice. You always have to fit them to the area that you're working in, the context you're working in. If you're doing it in primary care, it's going to be different if you're going to do it in secondary care. It's obvious. If you're working in an inner city area, you may have to change it from, say, going into rural Lincolnshire. So how do you do this? So what are the things? So we try to work out what are the things that must not change. If you change them, then it won't be as effective, and it won't be this thing. It's not what it's on. It's not the label on the tin. You know, it's not the Ronseal, if you like. It's some cheap imitation. So it might not work so well. And what are the things that not only can change, but should change to fit the local context? So it's a different way, or at least I think it's different. Maybe you tell me it isn't. So the problem that we were faced with is serious depression. Obviously, my area, this is my project, so I'm interested in that. And the problem is that this is a nice guideline, CG23, one of the first ones that were done ages ago. Then it was repeated in 2009 in CG90, and because it's a serious problem, they decided they have to have two guidelines. So 23, 90, 91 all say the same thing. For a person whose depression has failed to respond to various strategies, consider referral to a practitioner with a specialist interest in treating depression. Fair enough, that's me. Or to a specialist service. Now the problem is there isn't one of them in the country. So what is a person supposed to do? What is the point of having a nice guideline referring to services that don't exist? And it's amazing that someone hadn't pointed out this fact. You know, the CG23 was 2004. 2009, there still weren't any services, but I didn't stop it being recommended. And furthermore, even more damning perhaps, the systematic search of the economic literature for this guideline found no studies of depression at a service level for people in the UK, yet this is the second leading cause of disability in the world. So we decided we'll try it, we'll have a go, we'll do a specialist treatment team. I thought one on the board. My impression was, from previous experience, that early warning signs thing, I did a first study in 1999. By 2009, there were 11 studies, so I could do a meta-analysis. We've just repeated it in 2014. There are 54 trials of this intervention. So, you know, things mushroom if you can get one on the board. So we had a bit of a problem because the ethics committee that I went to, first of all, said, you haven't piloted this. This is not the sort of thing you can pilot because it's very expensive to set up and it involves lots of people. You haven't piloted this. So I had to meet the chairman of the ethics committee and he said, you're not going to allow us to do this study because it's completely original. Have I got this? Because if I have, I'm going to take this a bit further. Because, you know, research is supposed to be original. So you're not allowing me to do this because it's not original. Anyway, we got past that point, and we got 187 people, eventually did 3 studies. The way it worked is that we started off in Nottingham, tried to persuade people in other places in the East Midlands, but places in Cambridge said, that's a good study, we'd like to do it, so they did that. And Derby also agreed. And what we've got are quite severe people. So age 47, as you'd expect, probably more females than males. 23. Now, 25 is severe, and you wouldn't leave the house. You need looking after. So almost that level, but some of them were in that level. 16 is moderate depression. Baseline 60 is independently functioning, may be able to work, but 40 means looking after. So these are quite bad. How long have they been like this? 12 years, 11 to 12 years. I hate to say this to this audience, but if this was a physical disorder, do you think people would be allowed to stay like this? And in the last year, 86% of the time they've been like this. So that's the context. It's a pretty bad group. And this was what we found. People did improve over time. This is not compared to placebo. This is compared to what normally happens. So seeing a psychiatrist, seeing their CPN, they made this progress. And up to 6 months, no difference. But now it's starting to become different. And we're getting into moderate depression, mild depression. Now, how do we achieve this? Well, to me, the important thing was these managed innovation networks and these knowledge brokers. One of the reasons this doesn't happen normally is that these are sometimes not in separate directorates of trusts, sometimes in separate organisations altogether. So one of the things that commissioners like to do is send psychological treatments for depression out for recommissioning. Almost every CCG does this, and they do it almost every year. And it's awful if you work in that environment. You really don't know what you're doing. And dealing with difficult, depressed people and anxious people at the time that you don't know whether you've got a job or not is not a great setting or a great way of running a service. So we have huge logistic problems. So one of the problems I had with this was, well, we need What normally happens is that you get letters from one organisation to another, and by the time that you receive them, they're out of date. So they worked out how to use IT, how to do this in real time. We organised the service in a different way so that each knew what each other did. What happened then was, because the psychologists and the nurses delivering the psychological treatment knew there was a psychiatrist on board, they took more risks with the treatment. They started taking on the people who were suicidal. Normally, they get sent away. So it's one of the ironies of treatment of depression. As soon as you get too bad, you can't have treatment because you're too risky for us to handle. So all of that was sorted out, but not by me. The other thing that happened was the service users said, well, actually, the other problem we know we have is that we can't, you treat us for a while and then we're just left to our own devices. And we understand there's no more money in the situation. That's what they said. Why don't you help us to set up our own groups? Show us how we might do them. And so they now exist in Nottingham. They now exist in Derby. So anyway, none of this mattered to our commissioners or our service provider until we showed them this data. It didn't matter that people improved. They weren't interested in that. Wasn't terribly interested in the cost of it either, really, within reason. But what they were interested is the fact that 45% of these people in the intervention went back to primary care versus 20% in the treatment as usual. They like that. So that's now a reality, and that means that we have gone from research, so an idea that was only there in 2009, to a trial, to a service that exists in 2014. So it isn't just, this is from Denmark. That idea is not unique to this country, and around Europe, people are catching on. The important thing is that that you select people who are severe enough. So this is bipolar disorder. This is from Denmark. Basically, what they did is they looked at people being treated for mood disorder and ended up in hospital on the first, second, or third occasion, randomised them to treatment as usual or the specialist intervention. And the startling result 6 years later was mainly because many less people ended up in hospital, was the patients did better on all outcome measures, and the cost was 2/3 of the normal treatment. That's the kind of thing that we need to do. So I'm trying to interest our commissioners in this particular study. It needs replicating, and I'm sure there needs to be a British equivalent. So thank you for listening. I'm trying to, I don't know if I've entertained you enough, but the scale of mood disorder means we need new solutions. So the scale of the problem, we just can't carry on doing what we're doing, and I'm afraid new drug treatments are disappointing. I would love to see some new drug treatments, which aren't, but they just aren't available at the moment. When I do some drug trials, I haven't seen anything that is particularly, a paradigm shift or is really doing things very much different. Self-management supported by technology is one of the ways that we could do this. Group psychoeducation treatment, treating in groups is another way. But maybe because these are relapsing remitting conditions, for a group of people, collaborative care with early warning sign systems supported by technology and remotely by clinicians and maybe more closely if it need be. And then selected groups, not just let them fester in our hospital clinics, but give them intensive expert treatment as they should have. And then the Clark approach is just some way of speeding the whole process up. So those are the sort of modern approaches to mental health, which is what I wanted to talk about. So I hope that's, that is what you wanted to hear. Thank you very much.
Thank you, Richard. Are you willing to take questions?
I'd be happy if you're happy to stay to, yeah. Yeah, a very good question. A very good question. It was also the Department of Health commissioned a piece of work to see what would be the most, what would be really cost effective to do, and that came out near the top of all things, because it's not just the healthcare costs. A lot of these people end up in prison, and a lot of people end up in chronically unemployed, so, well, the sad answer is, of course, not enough. And there are some, some searching questions that need to be asked about all of this. It is another area of work. I mean, it's probably no great secret that most of the political parties, as I understand it, are considering yet another reorganisation of the NHS when they come in, mainly because of the problem of the elderly, because effectively health and social care need to work better together, and they just don't. But the other area where it really is needed is exactly this problem, because most of the services, you can actually flip a coin whether you're going to go through a social services route or a health route. And they don't talk to each other, they don't work together, they don't even think the same way. And so we get a very poorly coordinated treatment, at least in my view, for problems where there is already evidence, things like people with conduct disorder, which if you're not careful can, particularly if it's mixed with a bit of attention deficit disorder, can lead to early involvement with the police, prison, and a life of like that. Costs a fortune to keep people in like that. There's already evidence that if you make the right intervention at the right time, this more than pays for itself over and over again. Yet we don't. And one of the things we don't do is because it is difficult, and we need all the statutory services to work together to do. So not enough effort. There are, attention deficit disorder was one of the conditions. That is the most common childhood condition, and we're trying to see whether more objective measurement comes in. At NICE, one of the most common things that gets requested over and over again, some of the things that NICE always has to go to the House of Parliament to discuss, is giving children these kind of poisonous medications, not just the stimulant medication, but antidepressants and antipsychotics. People find that idea revolting, let's put it that way. People worry about the effects on growth, worry about people's cognitive abilities. Most of these drugs can be sedating, there's a lot to do, more objective measurement of things, better working together. All of those things are things we need to do. Sorry. There's Nikos and then there's David. So,
this is very impressive. Of course, you talked to us about the mood disorders. So should I assume that in other fields of psychiatry we have similar efforts to the same degree?
No.
Or is it, you are a funny guy in Nottingham, so that's why we have this explosion of stuff here?
Well, one of the things that one needs to understand is that mood disorders are more treatable than most things. So one of our problems, for instance, what is considered a response in depression is at least 50% reduction in symptoms, if not full remission of the symptoms. The similar criteria for schizophrenia is a 20% reduction in symptoms, if that's seen as a success. But the fact is, if you've only had a 20% reduction in your symptoms, you're pretty bad. So the problem is probably even worse in some things like that. So the conditions I deal with, although we haven't got new drug treatments, at least we've got a lot of different types of them. And there are real differences between them. There are also lots of effective psychological treatments. And our problem is more how we organise ourselves. And you also have to work through quite a long list of them. So I didn't explain, but in the depression specialist team, we attempt 4 different approaches to treatment in a year. And what normally happens is that people languish after 1 or 2, and then people don't try enough to move things on. That needs to change. Whereas in schizophrenia, the problem is that there's one drug group. There's one drug which is very, which has to be monitored so carefully, but is an improvement. But so far, it's the only one. But if you're not careful, it will give you, severe blood dyscrasias and kill you. So it has to be monitored very carefully. That's called clozapine. And still, that's all we have. We have that, and we have some psychological treatments. The psychological treatments that we've got to treat 20 people. You treat 20 people, one person will be better. That's a number needed to treat, which is pretty poor. So that's the problem. The whole of mental health isn't necessarily as rosy. The real opportunities are in things like mood disorders. The big opportunities in anxiety disorders, and one of the banes of being a psychiatrist is you have to live with, all through, except for the beginning of my career, we had to live through this concept of SEMIs, which stands for serious mental illness. I think it's a type of house, and I don't like the concept of a SEMI. And SEMI is not SEMI by in terms of what effect it has. It's by whether you happen to have, fortunate enough to have schizophrenia or bipolar disorder, which is taken as serious. But it seems to me, if you can't leave your house because you've got agoraphobia, a type of anxiety, you can't go to work and you can't be independent due to that, or obsessive compulsive disorder, and these are far more common, then in what sense is that not serious? But we don't, because they're not considered serious, we don't have proper resources for them. Even worse is that the treatments for those conditions are highly effective. So we're not delivering highly effective treatments to people with problems. Anxiety was 7th on that list of in the world of disabling things, and then probably much worse than even the treatment on depression and bipolar disorder is the way we treat people with anxiety. It's not fashionable to consider them as serious. There's no money to be spent in research, but it's actually numerically it's probably the most common of all mental health problems and can ruin people's lives. So we've got issues like that, and so no, it's not quite as simple or as rosy as this. But some of this is also some of this we could do better, and it's not just me in this. I may have presented it that way, but there's a whole team of people, and there are people around not only just around this country. I showed you some from Denmark, but there are people in the Netherlands. There are clerks. The first clerk in Australia has now been set up. But clerks weren't originated in this country. There were veteran administrations, things called queries in the United States. The original idea came from Canada, and so I think these things are being developed, and I think what you're seeing are early attempts to try to do this in this country. That's not the way I described it is the way that we're doing it. There are other ways of doing this. And for some types of health problems, this is not the right way of approaching things. So when we were discussing this with Leicester's a greater interest in prevention of treatments. Well, prevention needs you to go out to millions and millions of people. You can't get them all coming to a network of the one type I described. It's just not going to work. So you have to have a different approach for that. But that is the way, one of the ways forward. So, David, do you want to?
Yeah, thank you very much. I mean, it's been an eye-opening experience listening to you talk about the magnitude of the problem.
Yes.
In the last 48 hours, we've had this big discussion about care data and the linkage of primary and secondary care information for research purposes and management of the NHS. Clearly, there's a misunderstanding in that debate going on. But it seems to me one of the solutions to enhance people's understanding is to give examples of where care data could really help.
Yes.
And I was really wondering whether your dimension of your problem in psychiatry is an area where an example of how this combined data set between primary, secondary and tertiary care could really be used to demonstrate the benefits to the population in the future, given the under-provision and misalignment of the problem versus the solution.
Well, I'm sure that's true, and mental health area was one of the prime areas. In fact, dementia is probably leading it. And Nottinghamshire Healthcare Trust, which is the trust I worked in, was in a small consortium of trusts, mental health trusts around the country, which was really not only going to link up actually in this country, but was going to link up to a wider European network. I'm still hoping they can, but you know, the sensitivities around this are enormous. It would be very useful to see, you know, actually work like the Clark work really need data on a much bigger scale in real life practice. It's all very well, even doing it the way I've shown it, that's still under a controlled trial kind of setup. And what you really want to know, and it's what we're going to try to do with this idea in the next 5 years, what if you take all the university people out, you know, and they're not being monitored so closely, but we still persuade them to collect routine data. I mean, there are numerous ways one can collect data on mood these days. So we've tried to set that up, and we want to see. But wouldn't it be better, we still have to make special efforts to do this. Wouldn't it be better if we could just get this routinely from the information that's held already? And that is, of course, the vision. So in the mental health area, that is very much the vision of Geraldine Strathdy, who's the new mental health czar. It's still, I don't know if that's the proper term for them these days, but there's someone doing this, and that's the first thing that she will say, if you ever hear her, that we should do this. With a problem like this, where it's 1 in 4 of people, I mean, obviously, the other thing that is really a problem with mental health is it's been stigmatized. And, but if it's 1 in 4 people, it's getting to the point that it's not a minority, is it? You know, so they're not all as bad as the ones I've been showing, but it should become, it is increasingly becoming normalized. You know, the fact that so many people are now prepared to say that they have, you know, at least one of these conditions is a sign that something has changed from before. And then having routine data to see what actually happens in practice, data that's believable and is worth having, which is another issue, is the next step, really, isn't it? So, yeah, maybe if there are examples.
Seems an irresistible argument because
Yeah.
finance associated with what we do with asthma.
Yes, yeah.
Your drug spending in psychiatric conditions is top of the list in terms of prescribing.
Yeah, and you know, in primary care and general practice, I mean, I'm sure there are plenty of GPs here who can tell me better otherwise, but often the most challenging patients, it seems to me, when I hear them talk, are people who have combinations of physical treatments, of physical problems and psychological problems. And the way we organise our services is into compartments. So you either have one or another, and you know, we're not very good at managing the physical health aspects of people with, you know, things like depression. In fact, that specialist team spends quite a lot of time sorting that kind of thing out. But equally, we could do better in other ways, you know, in the other direction. Yet we work in the basis of thinking of, you know, best problem lists. And again, that's not all right, because these things are not like that. They're not separate problems. They interact with each other. There is also, you know, I have to freely admit, the other thing that we're talking about, you may say, well, where are all these people coming from? You know, that you're talking about 1 in 4, that's like, and is this maybe medicalized? There is an element of that. You know, so some of these people that are labeled depressed, you would have probably said people given up hope, people who are demoralized, you know. And indeed, the answer is not to give them all antidepressants, but it's as much to do with how you talk to them, to motivate them to do things. Really good doctoring skills that many people already have and were taught ages ago and still are being taught. So some of this, what would be helpful is at least to recognise the problem and to know that you should put some more emphasis in this. So I think I should say that, because I don't feel that I want to paint a picture that everyone should be on antidepressants or anything like that. So, right, well, thank you very much, and if no one else wants to answer any more questions, then Nikos.
So Richard, that was fantastic. That was
Right.
fantastic. So when I say usually my patients, I say that yeah, there are problems. There are the tablets and there is a talking therapy.
Yeah.
And I would imagine that in a few years' time they'll say that there are some computers as well, and
Yes.
we can put some monitors. So I expected a bit of a couch discussion and Freud, how do we manage the mood disorders. It was revealing. We learned about Catherine Zeta-Jones. We learned about all sorts of stuff. I think it was fantastic. It was very good. Very pleasant.
Thank you.